Good morning, all. Dr. Saju has joined.
Yeah. Good morning. Good morning, sir.
Yes. Okay, thanks. So Dr. Saju will be the program coordinator. So he will be coordinating today's session. Over to you, Saju. Okay, you can take it forward.
Hello. So good evening to all. So I welcome all of you, including the expert molecular scientists for today, the geneticists, all the oncologists, as well as the postgraduates who have joined for today's virtual molecular tumor board. So before we start, few housekeeping announcements. So the attendees who are attending for today's meeting, kindly mute yourselves. But you are free to unmute and ask queries during the discussion time. And the order of discussion will be the presenter will be presenting the case where the NGS report also will be shown. Then the comments on the NGS report will be given by the molecular scientists. Then the experts will address the queries mentioned in the presentation and will discuss the ideal as well as the practical approach to the case. And the final conclusion will be made by Dr. Narendran for each case. And also try to stick to the time as much as possible. Try to be crisp while making points to save time. So we have two chairpersons today, Dr. Tejesh as well as Dr. Ashwin. I hope they have joined. So Dr. Tejeshwar, are you there?
Yes, sir.
Yeah. So you can introduce yourself and then we will start the first case.
Yeah. My name is Dr. Tejeshwar. I'm working as an assistant professor in Department of Medical Oncology at NIMS, Hyderabad. I thank the organizers for giving me this opportunity. Sir is there, sir?
Yeah, I will invite the first presenter for today.
So, okay. So we'll start, shall we start then?
Yeah.
So we'll go with the first presentation. Actually, all cases are challenging cases and they are very interesting. And these are all the cases which we are seeing in our daily practice. So we'll start with the first case by Dr. Muhammad from Baby Memorial Hospital, Kozhikode.
Okay. Good evening, everyone. I am presenting the case of a 27-year-old female. She was presented with vague lump in the left breast in February 2023. It was upfront. It was initially when she came to us. It was she underwent mastectomy, left side mastectomy. It was the pathology report was invasive lobular carcinoma with N3 like N3 lymph N3A T3 N3A, and after that we have done the scan PET-CT that showed multiple sclerotic and lytic lesions that is involving the sternum, left scapula, few bilateral ribs, sacrum, and a few dorsal lumbar vertebra. So it was an extensive bone metastatic disease with T3 and 3 primary tumor and the lymph nodes. So in the diagnosis was actually 2022, June 2023. So she was put on hormone therapy with loprolide plus letrozole plus ribociclib. She was next slide, please. So she was response was assessed every 4 months with PET-CT scan. Initially, it was showing good response. All the vertebral lesions and the bony lesions were healed and the sclerotic. It becomes sclerotic. While during the follow-up in the May 2025, there was a clinically palpable lump in the opposite breast. And we have repeated the PET-CT that showed there is a 1.5 centimeter lump in the opposite breast. That was like just like a subcutaneous plane, and there was multiple non-avid lymph node also was there in the axilla. So we have done the biopsy from the lesion that showed again invasive lobular carcinoma, and we have done the repeated the AHC that also showed ER strong positive, PR and HER2 was negative. And now because of this first progression, we have done the NGS from the biopsy specimen as well as from the liquid biopsy also we have done. So that NGS has shown, tissue biopsy NGS has shown there is a NTRK fusion. And the liquid biopsy was negative for any ESR mutation or PIK3CA or AKT mutations. So in short, this is a 27-year-old premenopausal lady presented in 2023 July with breast lump. On evaluation, it was extensive metastatic disease. ERPR strong positive and HER2 was negative, and she received almost 1.5 years of almost 2 years of letrozole plus ribociclib, now with the progressive disease, and the NGS showing NTRK fusion.
So please show the NGS report. Next slide.
This is the NGS report, sir.
Okay, first I would like to ask the molecular scientist regarding this NGS report. Any comments are there? Then probably we will address the questions mentioned in the previous slide.
Sure, sir. Yeah, thank you. I'm Arun here. So for this quite a interesting case. We have a hormone positive breast cancer developing an NTRK fusion. We don't know if it was developed or whether it's there from the beginning, but mostly it would have been a development. What is important to note here is that the NTRK was picked up in the tissue biopsy, but not in the liquid biopsy. I think that's a point of learning for all of us here. Again, we all know many of the labs do offer liquid biopsy based fusion testing, but the sensitivity of fusion pickup is pretty low in liquid biopsy. So it was very good that tissue biopsy was done for a CGP and it was picked up. Incidentally, the liquid biopsy is also done by the same laboratory, and Guardant is one of the best in terms of liquid biopsies. But in spite of it not being able to pick up in the liquid biopsy, talks either about the biology of the tumor or inherent lesser sensitivity of the technology to pick up fusions in liquid biopsy. Having said that,
Arun,
yeah.
one point I was just going. See, one is lobular carcinoma. So whether the tumor shedding is one aspect, then
Exactly.
you see the tumor fraction is only 0.4%.
In the liquid biopsy,
yeah,
I was coming to that in the next. Absolutely, very valid point.
Okay. You continue. Probably this explains why we were not able to pick up in the liquid biopsy. That's
liquid
what I was
biopsy. Absolutely.
You proceed, Arun.
So in terms of this fusion is actionable. I think there are even case reports of the same fusion in other tumors. So this is actionable, but whoever is projecting, can you just come down like a lot of pages down? You have the liquid biopsy report. Can you just come down? Further down, keep coming down. Till I say stop, please coming down. Down. Down, further down. Down. Further down.
Page number 4 of liquid biopsy. Still you are in the tissue. I think Dr. Arun wants to come to liquid.
Down. Yeah, liquid biopsy.
Page number 4.
Yes. You can stop here.
You can stop here.
Up. There was a graph you could see. just above. Please go up.
Yes.
Up. No, you
Up,
went
up,
too
not
down.
down. Down, down.
Up,
Not
up,
down.
up.
Go up. The first page of the
Page-
The
liquid
first
biopsy.
page of
No, page 25. Page 25. We have labeled it. Go to page 25.
page
25.
25.
Just go to page 25. We have labeled each case. Just go to page 25.
There's 39.
Yeah. Go to 25. Yeah, stop it.
Just a bit up. There is this. Okay. So one very important marker, which as Dr. Arun Seshachalam was mentioning too, in any liquid biopsy, please see what is the tumor fraction. This is for the general audience who need to know a bit about this tumor fraction. Tumor fraction tells you about the total DNA from the tumor that was picked up in the blood of the individual. Because in the liquid biopsy, when you extract the DNA from the plasma of the person, you get both germline DNA, that is the normal cells DNA also, as well as you get the DNA from the tumor. Now, 0.4% is a tumor fraction, which means if there were 100 DNA fragments that were there in the plasma, only 0.4 of them were from the tumor. Now, this typically happens for multiple reasons. One, most commonly, certain tumors are inherently poor shedders of DNA. You do have tumors like sarcomas are very bad tumor shedders. Sometimes when you do a chemotherapy and when you do a radical therapy and then immediately take the blood of the DNA, this tumor fraction is going to be very less. So if the patient is on long therapy, but there is a lot of matter, so ensure the disease burden is big enough and the tumor is not is a tumor that is known to be a shedder of DNA. That if we ensure before doing the liquid biopsy, then the sensitivity of the liquid biopsy increases. Now, the natural question is going to be, what is the cutoff? Now, this is again empirical in nature. Based on studies both by Foundation Medicine as well as Garden, they have identified tumor fractions above 10% is extremely sensitive. Like the false negative rates are going to be very less. But getting a tumor fraction about 10% is, you don't see that in almost all the cases. So anything above 5%, at least I have seen the false negatives to be less. So for complex genomic markers like translocations or fusions, ensure you get a very high tumor fraction. So if the tumor fraction is less, you should be wary that there could be a possibility of false negative. So this is just the point I wanted to make. Apart from that, but again, the way to interpret this here, you see the TP53 is 0.3%, which means of the 0.4% of the tumor fraction, 0.3% is the TP53, which means almost 90% or all the tumor cells that were tumor DNA that was there, it had this TP53 variant, which means it's a very dominant clone. But that small volume of DNA was not sufficient to pick up the translocation of the NTRK, right? So this is just the point. But in addition to this, I mean, if next, I think we should discuss about the therapeutic aspects. It's targetable NTRK fusion.
Arun, coming the same point, just Silambarasan and Dr. Arun both. See, will the lab limitation or lab validation assay, what is the tumor fraction that is validated for that particular lab? Will that help? Because many of the labs give what is the minimal circulating free DNA percentage they can be sure. Will they mention somewhere based on the lab assays and lab validation?
Ideally, the lab should be able to give you that if you ask them about for their validation studies. Okay. Now, what is the minimum mutation load the lab is able to detect in the liquid biopsy is one point, and what is the minimum tumor fraction they were able to go down to pick up that genetic variant is a second point, which could be available in their the documents. If you ask the lab validation documents, they would be able to share. Labs like Guardant and Foundation, they have already published it. It's there in published literature, but nevertheless, you can very well ask them to.
Awesome. The other point is lobular carcinoma is known to be a poor shedder. Probably
Poor
that may be,
shedder.
that
Yes.
may be also one of the reasons. Yes.
So yes, thank you, sir. Like Dr. Arun mentioned, if I have to simplify the same thing, the tumor fraction is almost equivalent to the tumor content of the block sample. So when we are giving the tissue block sample to the NGS testing, so there will be a minimum cutoff of 10%, 20%, 30%. Like that, lab to lab, that will vary. Because of their protocol they follow, because of the optimization they have done with their methodology and all those things, some labs they will prefer 10%, some labs they will prefer more than 30%. So like that, here the tumor fraction also, most of the labs they do calculate, but they won't reveal it in the report. As Dr. Arun mentioned, Garden will tell, Foundation Medicine will tell, and certain other labs are telling. So if you are asking the lab, what is the tumor fraction? If it is more than 5% or more than 10%, that means you can rely on the data to take your clinical decision. Anything less than 5%, you need to look at that report of liquid biopsy, whatever the mutation they reported, with a suspicious aspect. Okay, that is the first thing we can learn from here. And then again, I like to go back to the tissue report,
So,
basically. Can we go
Dr.
to the tissue
Pushpa
report?
here.
Yes, doctor. Yes,
Hello.
doctor.
So here we do consider tumor fraction we publish. Tumor fraction, the cutoff what we take is basically for the liquid biopsy. If it is above 20, the tissue, the report, whatever the liquid biopsy report is there, can be relied on, and the people need not go for the liquid biopsy. Suppose if the tumor fraction is less than 25, then we consider that as an approximate report, and we generally refer for tissue biopsy in that case.
Thank you, ma'am. Thank you. So that's why it will differ from lab to lab, basically, right? So that's a one learning we can. And can we go to the first report of the tissue?
And also, it will tell you the tumor aggressiveness also. The more is the tumor fraction, more aggressive is the tumor. And as sir said, it depends on the tumor shed also.
Yes.
Yeah, hi. Yeah, so Krupa here. So I think, for example, if you take a foundation one, they have a 30% cutoff. Guardant uses a 10% cutoff. So they have published it and they've standardized it based on their standardization. I mean, so I think different labs obviously have different. You'll probably have to check with each of them as to what their standardization are and what their published literature is. And again, as far as shedding is concerned, also depends on the site of metastasis as well. I mean, for example, if somebody with peritoneal metastasis, the DNA shedding is definitely going to be much lesser as opposed to somebody with either lung or liver metastasis. So I think the site of metastasis, the histology, the biology of the disease, all of that matters. For lobular carcinoma, as Dr. Arun sir also rightly pointed out. So I think all these factors need to be taken into account. Yeah, over to you, sir.
Correct. Sir, one more point I want to discuss. So can we have the slide back, please, with the tissue report? So the NTRK fusion mentioned over this report is very interesting. In the entire world, this is the first time this NTRK fusion partner has been identified. So that I have verified.
Go to page 10, Pratibha. Go to page 10.
First one. I'm not seeing the slide deck basically.
Yes, go to page 10.
I think the slide share is off.
Slide share is not there. Yeah, it's now coming. Sorted. Yes, correct. Yeah. So if you look at over here, there are 177 transcripts has been identified. Okay, that is one side of it. But this VPS13C NTRK fusion is the novel fusion. There is no evidence or no currently the clinical evidences are available for this particular fusion. Having said that, the main partner we are focusing or debating or discussing over here is the NTRK fusion. So one humble request to the clinician is as to the lab where the fusion takes place. If the kinase domain of the NTRK fusion is not affected, then the entrectinib or lorlatinib or other NTRK inhibitor will work. If the tyrosine kinase domain, if it is getting affected, there is a chance that the efficacy of the drug also will be affected. So that I try to go through the entire report. Most of the report of Genome or whatever the companies you are taking, they will tell which exact the region it is getting fused, basically. Okay, so that information is missing over here. Without that information, since it's a novel fusion, if it is a well-known fusion, I will not have any doubt. Since it's a novel fusion, kindly ensure the tyrosine kinase domain is not getting affected in the NTRK gene. So thereby you will be ensuring whatever the NTRK TKI we are going to take, that may effectively work for the patient. If we are planning to take NTRK TKI. Because I seen that the doctor is planning to take the NTRK TKI.
Yeah, Simbo. So, sorry for interrupting you. So,
Yes, sir.
if you look at the NTRK, this is an NTRK3 fusion, right?
Correct, sir.
We know there are
Yes.
NTRK 1, 2, and 3. So, this is an NTRK3 fusion. Whereas VPSC 13A and C have actually been reported in literature to be actually an oncogenic driver mutation. I mean, like here we're talking about a true activating fusion here.
Yes, sir.
That has been actually reported in literature, both, like I said earlier, 13A and 13C as well, as far as the NTRK3 fusion is concerned, which is what has been picked up here also.
Yeah, it has been reported. And one other point is generally labs like Foundation and Guardant, when they are giving out treatment recommendations, can you just go up? When they say available treatment is, I think above. Here it says entrectinib, right? So here, the green one. When they say associated FDA approved therapies, they don't give that for fusions which disrupt the tyrosine kinase domain. So they ensure that that is taken care of before. That is true for labs which are FDA approved, not for all the labs. So what Silamarasan said is a very, very important point. But it's always good to again go back to the lab and ask. But point is, you need to have that to be extra cautious when you're not getting tests from a FDA approved lab.
Yes, thank you, Arun, for the clarity.
And also, I think, whenever they talk about approved therapies, they talk about tumor agnostic therapies here. And, we do that only when we exhaust standard of care options. Once we've gone across or, you're exhausted your standard of care options, then you're looking at tumor agnostic therapy. So I think that's another thing that needs to be noted here as well. But this NTRK3 fusion has been described. This particular, the partner fusion gene as far as VPSC 13C is concerned, both 13A and C have been reported.
I just have one question because Arun Kumar was specifically telling that FDA approved lab. Slightly, I was more concerned. See, if a novel mutation is there, it's not reported before. Is it not that the lab should report it as undetermined significance, something like that, rather than telling it's pathogenic? It holds good for all Indian labs or non-FDA labs also should do the same, right?
So here, even if it is novel, Dr. Arun, what they have to see is the biology of the fusion partner and the location of the fusion in the target gene, in this case, NTRK. So if I have to go a bit deeper into this, most of the NTRK fusion partners have a very strong promoter region. So when you see VPS 13C, the promoter region of the VPS 13C is cut from the gene and it's pasted along the NTRK3 gene, wherein the NTRK3 gene's tyrosine kinase domain is staying intact. So I know how that works in Foundation and Guardant. They check these points, whether this promoter is the fusion partner's promoter is a strong promoter, and whether NTRK3 tyrosine kinase domain is really intact. And since this is done by RNA expression, they would also have seen the background expression of NTRK, the number of reads is there. So, which is why I'm like 99% confident this is a good, or even more than that, this is a correct fusion reported. Now, there is no binding for every lab to do all of this. So I have seen wrong NTRK calls. I have seen those from other laboratories. And then when we go back, it has got picked up. So the false negatives were picked up and it was actually a wrong call. So it's very, very important, and NTRK is notorious for that.
And yeah, so and should we also in that case then look at doing an IHC to look for protein?
Yes.
on
Yes.
Exactly. Orthogonal validation by FISH, I would recommend. Here it's a fusion, so FISH would be even more ideal if the probes can be designed for both the partners.
No, see, Silamarsan, the point is, I think IHC is also good here because it also tests whether the protein expression is increased. So FISH does not, it tells us if translocation has happened, but to confirm protein expression to be there, I think IHC is really helpful.
Really helpful, yes.
Yeah, I think that's part of the SCAT recommendations as well.
Yes, yes, it is.
Correct. I agree. IHC, we can do it immediately.
Yeah.
And it's available in India. NTRK IHC, PanTrek IHC is available in India.
It is there, true.
So
yeah,
in this
basically-
case, you recommend like without IHC, we not to proceed with entrectinib. If IHC is negative, we will not offer.
I mean, because entrectinib is a pretty expensive drug. If you want, you can do the IHC.
Okay, so it's not mandatory. You can.
It's not mandatory. You can proceed with the drug directly, but if there is an element of doubt, you may want to do IHC.
Yeah, next we will discuss the best treatment options. So basically, this is second line of treatment only. So we have not exhausted the next treatment options also. So Dr. Tejas, sir, what is your comments on the best ideal treatment for this patient?
So for this patient, currently so now at this point of time, is this patient is having an ERPR still positive, or whether it is changed?
So this patient, the last biopsy ERPR is positive and HER2 is negative.
Yeah. So HER2 is negative. So in my clinical practice, I'll go with a second line fulvestrant based therapy for this patient as she progressed on hormonal letrozole and along with ribociclib. So, but it is good that this patient has underwent this novel mutation testing, and then so ideally what we are doing is we'll check for any ESR mutation is there or any PI3K mutation is there, and then we are going for a targeted therapy in those subset of patients. But this patient, good that underwent an comprehensive genome panel, and this fusion was detected, and we are having an excellent therapy for this excellent approved therapy like entrectinib, larotrectinib at this for her. So if the patient is affordable, then I'll go for an targeted therapy for this patient. But in my practice, most of this patient cannot afford these drugs. Mostly I'll end up going with an hormonal therapy or chemotherapy.
So yeah, Saju. So I think this patient had ER positivity and PR negativity upfront. What was the repeat biopsy? What did the repeat biopsy show? Was it also ER and PR positive, or PR was negative only ER? And if so, was it strong positive, or was it weak positive, low positive? And what about the HER2 status? Is it low, ultra low? I think we need all of these informations on the repeat biopsy as well. So if the presenter is there, they can probably clarify.
Yes, sir. It was ER was strong positive and HER2 was 0 and PR was negative.
So on the repeat biopsy as well. Okay.
Yes, sir.
Hello, sir. Hello.
Yeah.
So that
Naren here.
Yeah. So anyone are having any other opinions in the management of this patient? So apart from hormonal therapy, are there any other like who are willing to go with an targeted therapy at this point of time for her?
I think Dr. Naren to make some comments.
Sir, Naren here. Just wanted to know this patient at progression. We initially had she had multiple bone mets. On progression, whether the bone mets sites under control only, it's a progression in the opposite breast and the axillary node, or it's all side progression.
Actually, the PET-CT, the bone lesion, it was initially also, it was not, uptake is not that much, but the sclerosis that has increased in the recent PET-CT.
So
we
now
cannot comment it whether it is a progression or it is like a stable disease.
It's a lobular histology. It's a lobular histology. So
yes.
Uptake, yes. So that's one thing, and the other thing is, I mean, like probably I would also look at probably continuing the CDK as well. We have data to continue that beyond progression. Probably any takers for that, for switching the CDK or continuing on the CDK as well. If you
Maybe
just go with fulvestrant.
Abemaciclib along with fulvestrant.
Fulvestrant also is an option, because this patient has responded for 1.5 years. So makes sense for us to go ahead and continue second-line hormonal therapy as well. Probably go with Avima and fulvestrant. And reserve your NTRKs for later as part of tumor agnostic therapy, because that's where the current FDA-approved indication is. I don't think
what not to consider here, sir. We know they think female, it's NTRK is an aggressive fusion, and we don't have other ESR and other AKT mutations. We know later lines we can consider, but considering the aggressiveness and why not consider now itself with hormone therapy?
The problem is,
You want to give entrectinib at this point of time, Naren?
Just wanted to ask opinion experts. So whether we can give hormone therapy with entrectinib.
Problem with that is, from a mechanism point of view or from a biological point of view, it makes sense. From the rationale, I mean. But unfortunately, there's no data for us to do that at this point in time. And obviously, it's second line for this patient who's actually done well with hormonal therapy for 1.5 years. So I think that's where the skepticism is. And we don't know if they have overlapping toxicities. For example, hepatotoxicity is overlapping between both. So we don't know. So those are unanswered questions. So probably a clinical trial would be in order to address those issues. Until then, I think we don't have the data to combine both in this setting, especially for a young 27-year-old who's progressed after 1.5 years of hormonal therapy, in somebody who's still hormone receptor positive as well on the repeat biopsy.
And what your take on lobular versus ductal? We say that second line, third line, we have other options. So whether the same options will have a same response in lobular versus ductal, sir?
Definitely.
I mean, yeah.
Lobular, I think the chemo responsiveness is definitely much lesser as opposed to ductal. That's number one. But the hormone, they tend to respond slightly better to hormones when compared to chemotherapy. So, here you've already, the proof of the pudding lies in eating it. And here you have somebody who's actually responded for 1.5 years on hormone therapy. And 27-year-old, was ovarian function suppression was also done here. So I would also suggest that the patient gets a lab PSO done. That's going to take care of the issue as well, rather than continuing on completely only on OFS in the metastatic setting, because this is completely in the metastatic setting. So I would also push for a lab PSO to be done and go ahead and continue hormonal therapy. I will accept time as per obtaining a CDK with fulvestrant.
I think what Kripa said is a very valid point. Actually, although it is tempting seeing the NTR fusion and the transcript levels, it's a quite high transcript levels that is positive. But still, I think probably we need to try it after second, third, or fourth line. Probably for next line will be, because 1.5 years still hormone sensitive. Probably that line of treatment will be more possible. Probably reserve entrectinib, and if entrectinib the patient is not able to afford, probably other FGF inhibitors, TK inhibitors like lenvatinib, all, but it comes in the later line of therapy. That's what I also thought. I think I approve. I think I go along with Kripa. Anybody wants to start entrectinib straight away, not waiting, seeing the NGS report here?
What if we start for the second line, we go for the fulvestrant based and continue abemaciclib, change over to abemaciclib. If there's a short PFS, within a 2 or 3 months PFS, still we go for chemotherapy and then again try and then go for NTRK inhibitor here, or in that case, shorter PFS, we have a targeted fusion, we'll go for entrectinib.
Yeah, I think my opinion, I think I will go for chemo, then reserve entrectinib for the next. That's what I would have thought, rather than straight away start with second line entrectinib.
I would also agree with that, sir. I think, obviously, this patient is chemo naive as well, has not been exposed to any chemotherapy. They have obviously start off with chemo and then use your NTRK inhibitors for later.
Okay, and then at that point, you advise again repeat NGS.
Yeah, definitely. At progression, also repeat the receptor status, because if there is a loss in receptor status, if the patient becomes triple negative, that opens up a lot of other options as well, Narendra. So at that point in time, you could look at platinums, and then you could look at saxituzumab, Govitic, and so many other options as well, which will open up even PDL1 positivity for triple negative. If it becomes TNBC, or if it becomes ultra low or HER2 or low, then it opens up TDXT as well. So many options, later lines, and this is also PR negative. So that's probably one of the reasons why people go on to develop endocrine resistance also, prime candidates.
And
just
one more thing, Kripa, see that liquid biopsy didn't pick up the NTRK. That is one thing we should like. Whether there is a multiple clones that is existing, the primary is having the FGR fusion, but the metastatic sites, whatever the shedding is happening, that is a different clone. We don't know. That also we should keep in mind.
Very true, sir. And probably like we discussed earlier, we could also look at doing a pan NTRK by IHC also to look for protein overexpression before we actually offer them the drug. Could do that as well. If we
So
just
just for discussion, we go by line treatment as FDA approved. So really, will this broad NGS is necessary at this point of time? Then the question comes, whether the limited panel itself sufficient here at the second line.
see only because you've done such a broad-based NGS, you've picked up all the other mutations as well. Like for example, your P53 as well, which was discussed. Even though that may not have therapeutic implications, we know it's prognostic as well. And so we know that. See, for example, let me tell you, you do a broad-based NGS later on. How do you know whether this mutation has been present at baseline or it has evolved now? Right? We talk about clonal evolution and selection pressure hypothesis as well, right, Naren? So I think it makes sense for us to do a broad-based NGS. So what if your broad-based NGS now has picked up a PIK3 or an AKT or an P10 loss or any of those ESR1 mutations? How are you going to get all that information without doing a broad-based NGS?
That they do that they do it as a targeted or ESR1 and as for specific they do it. My question is, every time we do a broad-based NGS and finally we stick FDA approved is it's not this mutation, this fusion, we don't have FDA approved in the second line.
Exactly. So now that you actually see, for example, now you've been able to pick it on tissue but not on liquid biopsy, right? So there's a discordance, right? So that's only because
so maybe whether it's evolving or whether it's a new one, that information we can get with repeating every time the NGS.
It makes a lot of difference for us to know that and understand that whether a mutation.
Tumor biology, it will help to know the tumor biology and the evaluation of mutation.
This will also help us position where we're likely to use the drug or the molecule.
Okay.
Whether it's been present upfront or it's evolved, as a resistance mechanism or not. So multiple implications as to why you'd want to do a broad-based NGS narrative.
Okay.
SCAT recommendation, what they tell us, go for focus gene panels for the first one or two lines. Then they asked to go for broad-based at the later lines. In fact, the latest ESMO guidelines on genomic studies in metastatic cancer, you see, that is one of the recommendations they said. Go for focus gene panels initially and broad-based panel at a later lines. That's what they have addressed.
So again, sir, I mean, if you look at the SCAT recommendations, they have tier 1, tier 2, and tier 3 mutations that can be picked up. So if you're looking at, looking at for all of these tiers, tier 1, tier 2, or tier 3 mutations, then I think, like for example, let me tell you, we now have the data, the SERENA-6 data, which looks at using camizestrant if you pick ESR1 mutation without evidence of any any radiological progression as well. So even for those sort of strategies, moving forward, yes, it's not yet currently approved. Yes, agreed. But the phase 3 data, SERENA-6, camizestrant, using it, prior to radiological progression. So I think, for those sort of strategies and also for tracking it and also looking at whether the VAFs are coming down as a response to therapy as well, if you're using it. So I think moving forward, I think that's going to be really important for us. So I think if cost is not a constraint, we are in an era where we're doing even complex or reflex testing both on tissue plus liquid. So I think that's actually a norm even in lung cancer, as far as non-small cell lung cancer. So I think wherever possible or feasible, we're not wrong in actually offering a broad-based NGS right up front to understand all the molecular information, given that we can interpret it the right way and also plan for it, because it has prognostic relevance and also predictive as well.
Okay, can I summarize, sir?
Yeah, Naren.
Yeah. So this patient, 27-year female, metastatic disease, post 1.5 years on ribociclib and letrozole and leuprolide, now progressed with NGS history of NTRK fusion. As per recommended, as per the expert's opinion, the second line to proceed with fulvestrant with another abemaciclib, another CDK inhibitor, and if possible to consider for BSO or to continue leuprolide as ovarian function suppression, and reserve the NTRK fusion for the later lines after probably after third or fourth line of treatment. and consider IHC for NTRK to look for the protein expression also. And on progression, when you're considering for in third or fourth line, again repeat ERPR HER2 and NGS, and then you consider the fourth line.
So you want to keep it as a third line or fourth line?
I think that's a hypothetical question because, we don't know how the patient is going to evolve in later lines, right? Whether the patient's holistic be hormone positive or going to be triple negative or HER2 low or ultra low. So I think we can all sit and contemplate all day long, but we're not going to have that answer right now. So I think we should just stick to what we're going to do right now and then repeat a biopsy at progression, probably even repeat an NGS also at progression and take that call.
Yeah.
The patient.
Yeah. So during the next time also, when the patient progresses, we'll repeat an NGS for her and then we'll see. Yeah. Okay.
So this is the next case.
Yeah, I'll go for the next case. So I invite Dr. Ruhi Kumar from Shashwat Hospital, Rajkot. Dr. Ruhi, are you there?
Yes, sir. Good afternoon. Sir, am I audible?
Yeah.
Okay, sir. So good afternoon, everyone. Thank you for this opportunity to discuss this case. Next slide, please. This is a 71-year-old male who's diabetic and hypertensive, and he came with dyspnea on exertion and back pain. On evaluation, he was found to have stage 4 lung cancer with massive pleural effusion and bone mets, upfront bone mets. He required oxygen while admission, and because he was a never smoker, we gave him empirically, we started gefitinib for him. After his pleural fluid cytology and cell block came as adenocarcinoma lung, and IHC was an absent positive. And we gave him empirical gefitinib. He improved clinically, so we were expecting a EGFR mutation on his NGS, but it came out to be BRAF V600E positive, which was the tier 1, which was labeled as tier 1. Also, along with it, there was a MET fusion, which was also labeled as tier 1. So I just wanted to know the implication of a MET fusion along with this rare BRAF V600E. And the patient is affordable, so we were thinking of starting dabrafenib plus trametinib upfront. They were not too keen on chemotherapy.
Yeah. Can we go to the NGS report?
Hello. Ruhi, are you there? Yeah.
Some more. Maybe 46th page number 46 or 47, something like that. Yeah.
So this is slides. Yeah. This is the NGS.
Yeah, Dr. Arun, this is the major first page of NGS report.
Yeah. So, Silabasan, you can take it if you want. It's exon 14 clipping with BRAF. So please go ahead.
So the first this report is one of the non-classical way of doing the reporting. I don't know how this lab is doing the reporting. This is a clear MET exon 14 skipping, but they are put it out as a MET fusion, MET to MET fusion. I don't know what kind of reporting they are doing it over here, but very clear to the audience over here, it is MET exon 14 skipping. Okay, number 1. Number 2, when the BRAF mutation, when the BRAF V600E mutation, which is one step pathway down actually. So MET is the receptor, BRAF is the downstream pathway. So whenever downstream pathway is activated, in this case, BRAF V600E mutation, targeting the upstream is not going to be helpful to the patient. So the ideal choice, there is some evidences available, is the BRAF inhibitor, BRAF V600E mutation we can target. But in the lung adenocarcinoma, the treatment efficacy is less only. It is not as effective as colorectal cancer or any other indication. So in the lung cancer, trametinib based therapy, the evidence is lesser. But here I can say that because of the BRAF V600E mutation, definitely MET exon 14 skipping treatment is not going to work out. There are a lot of evidences are for there, anecdotal evidences, and as well as a few case reports and many other reports also present. So Chinese data also there, which is almost 200 patient data, clearly proven that the MET exon 14 skipping downstream, if it is BRAF mutation is there, it is not going to work out.
So, Simbu, if I can just interrupt you here. So,
Yes, sir.
we talk about the classical MET exon 14 skipping mutation, right? But that's a splice
Correct,
site
sir.
mutation. It's a single gene splice site mutation, right? Whereas
Correct,
here, I think what they've picked up is an exon 13 to 15 intragenic fusion, if I'm not wrong. Is it an intragenic fusion that they've picked up? And that's why
that's what actually I am also suspected, sir. I have gone through all these places, but there is no other places they have mentioned where exactly that fusion taking place. And
Okay.
they have mentioned only that the exon is skipped.
Okay, so it's probably functionally equivalent, but not the same. Is that right, Dr. Arun, sir, as well?
No, sir. I think this is exactly the same. See, what happens is at a DNA level, you pick up a mutation. The mutation is there in the exon-intron boundary. But the native RNA or the nascent RNA which have before splicing has the intron. But at the time of splicing, the exon 14 skipping happens, and this is what is the resultant of it. So this is an exon 14 skipping.
Yes.
So I think that's correct. So, functionally, they're both the same.
Functionally, it's the same. When you do an RNA testing, you get this kind of a fusion kind of a thing. There is a report, it is just below. I don't know if it is there here. There was a summary report of this same. Can you just come down, whoever is...
Next page.
Slide. Now you see here, RNA fusion, you see fusion gene A breakpoint is exon 13, fusion gene B breakpoint is exon 15. So the exon 14 is skipped here.
Correct. So probably an in-frame deletion of exon 14 is, that's what it's been. I mean, like, you'll have to take it as that?
It's not an in-frame deletion. When we use the word in-frame deletion, it means at a DNA level. But at the DNA level, you have the exon 14. But at the RNA level, you don't have the exon 14.
But so we can take this canonical MET exon 14 skipping?
Yes.
Yes.
See, any of the exon 14 skipping mutations you pick, see in any of the DNA reports, their RNA will be like this only.
Makes sense.
So what we are trying to say here, sir, the reporting style is not correct, but here it is a classical MET exon 14 skipping. That's it.
This is actually not the way you generally report a MET exon 14 skipping. You should end up saying MET exon 14 skipping is there.
Correct.
So this is a problem when we don't have, we do have guidelines for reporting MET exon 14. I don't know why it was not followed here, but there is no hard and fast rules of reporting in India. So these things happen.
So about the treatment aspects, we'll discuss next.
Yes, sir.
Yes, sir.
I think, usually these are considered to be mutually exclusive, just like how we talk about EGFR and ALK. But nevertheless, I think here we have, a rare scenario where probably you've been able to pick up two drivers. But I think, when we talk about driver mutations, conventionally RAS and considered to be slightly more hotter tumors. And probably if I might use the word warm tumors for MET and hot for KRAS and BRAF, albeit, without the presence of co-mutations like STK11 and KEAP1. But nevertheless, I think here I would agree with the plan of targeting the BRAF V600E, which is an activating mutation here, a class 1 BRAF mutation, and which we have an already approved, FDA-approved therapy. But right now, we have data called the front BRAF as well, which is basically retrospective study, where they have looked at, comparing between BRAF plus MEK inhibitors versus IO plus chemo as well. That is only retrospective data yet, but nevertheless, that actually showed us that using chemo plus IO was better because these were actually immunologically hot tumors. And was this patient a smoker or a non-smoker?
Never smoker, sir.
Never smoker. Okay. Fine. Makes sense. I think I would agree with your decision of going ahead and targeting the BRAF V600E Taiwan mutation, is activating as well. So with a BRAF plus MEK inhibitor. So I agree with your plan.
Sir, if I may, like you mentioned, IO plus chemo might work in this based on that retrospective data. So, like, is that something we should consider in the progression phase or?
Yeah, I think, 71-year-old non-smoker. So that's why I asked you that question as well. So,
Right.
of that. And have you gotten a PDL1 done as well by any chance? Because even on that retrospective analysis, they found that patients who have very high PDL1 expression, I'm talking about more than 50% or more than 80% to be exact, did seem to benefit more. And also patients who did not have a brain metastasis and the not so elderly patients as well. So that was based on retrospective analysis. But I think for your patient, non-smoker, elderly, more than 70, if I'm right, 71, I think
Yes, sir.
the BRAF plus MEK inhibitor right up front. Either dabrafenib plus tremelimumab or encorafenib plus binimetinib, because that's also approved based on the Pharos phase 2 data.
Okay, sir.
Both the options are valid.
Sir, so PDL1 is not done. We'll get it done.
Yeah, you can
But
definitely.
yeah, so we'll go ahead with targeted therapy in the front line as of now and see how it works, right, sir?
Correct, and that was your decision as well, right? So I think
Yes, sir.
I agree with your decision on that. Makes
So
sense.
just a question here. So the driver mutation which comes down the pathway is BRAF MAPK pathway. What if other mutation like PIK3, AKT, MTAR also activates downstream now, sir? If through the MET exon skip activation. So there will be two pathways activated when there is MET exon 14 skipping mutation, right?
What you probably trying to tell us is, Narendran, this is one of those resistance mechanisms. So, we don't have the data as to whether we can combine both BRAF plus.
I just wanted to know, as Silamasans has said, to
No,
block that.
sir, yeah. What Naren is telling that, sir, MET is activating both RAF also and other pathways also, downstream pathways it is activating. So if we only going to inhibit the RAF, then there is a chance of an activation of other pathway through that one disease progression can occur.
Yeah. Like I said earlier, obviously resistance mechanisms can be there. Obviously, we talk about this even for EGFR as well, where MET is one of those alternate signaling pathways that can get amplified. So what if you have an EGFR plus MET upfront? So at least there we are lucky we have amivantamab which acts on both. So here you don't have a single drug which can act on both. And we don't have the data to combine both as well. Like for example, dabrafenib plus tremelimumab plus capmatinib, or even tepotinib for that matter. So
Yes.
I think here it's fair enough for us to go ahead and act on the BRAF V600E mutation, which is type 1 pathogenic.
On progression, you again do.
Yeah, we'll repeat an NGS again, the same thing, the same funda. You have to repeat it, understand the mechanism of the resistance.
Okay, sir. Thank you so much to everybody.
So,
One
Dr.
question. Is there any role of any any VAF or like variable allelic frequency role in this kind of dual mutations?
To just tell which is the dominant driver mutation.
Yeah, to find out what is the dominant one.
Yeah, so just comment on that. It's a bit difficult when one is a SNV. In this case, BRAF is a single nucleotide variant, whereas the MET exon 14 skipping is a translocation or kind of actually not a translocation. It's a genomic alteration. So it's quite difficult to pick up the VAF because you don't get VAF for a MET exon 14 skipping. So ideally, certain labs now are even giving VAF for fusions and things like exon 14 skipping. But I don't think this lab has given VAF even for the SNV. So in this case, it's difficult to find out which is the driver.
Correct. And also, if you look at it, there is a VUS that's been reported at MET as well.
Yeah,
the exon 2 may. Yeah.
Exactly. So that's a VUS that's been reported on MET as well. So probably, which is why, you could, I'm more driven towards BRAF here rather than MET.
Yes, I agree.
So the VAF is mentioned in the variant details in the last line. So BRAF V600E VAF is 20.6%, and the MET VUS is 8%.
That's what. So we're not looking at the VUS. We have to look at The exon 14
driver.
mutation.
Yes, sir. So there they have mentioned read counts, but like sir said, we cannot pick up VAF in that.
So, which is why I think, we justified in going ahead with the BRAF plus MEK inhibitor upfront, Ruby.
Thank you, sir.
BRAF is the best. Currently, BRAF is the best option for this patient. So go ahead with the BRAF treatment.
Agreed.
Okay, thank you. Thank you, sir. Thank you.
Yeah.
I think
Naren,
it's
can you
summarized,
summarize?
so we can go for next case.
Yes.
Naren, are you there?
Naren?
You can summarize that.
Sir, can you hear me?
Yeah.
Hello.
Yeah, I can.
Yes, Naren.
Go ahead.
So this patient CAL metastatic CAL lung with BRAF V600E mutation and MET exon 14 skipping mutation. Since the downstream pathway is BRAF, expert consensus to target the BRAF for now and later lines of treatment to repeat the NGS and decide.
And to do PDL1 testing at this point of time, sir, is there any role?
Yeah, like I said, no harm in getting it done. So, but, we're not definitely going to act on it right away. But, it'll be good to have that idea as well to see whether it's a high PDL1 exposure or not. So, yeah, but we're not going to act on it right away. Because, like I said, elderly gentleman and a non-smoker as well. So, you can get a PDL1 done for sure.
Yeah. Next case.
So can we go to the next case?
Yeah.
Naren?
Good evening.
Okay, Dr. Bhuvana.
Yes, sir. Good evening, sir. I'm Dr. Bhavana from Vaidehi Hospital. Sir, I'm presenting a case of a 64-year-old female. She presented with the shortness of breath. And on examination on the left side, there was decreased breath sounds in the left thoracic region. We did a PET CT. We showed a 4.2 into 3.5 into 4.5 centimeter lesion involving the apico-posterior and superior lingular segment of the left lung. Also, there were multiple discrete parenchymal nodules of varying size and FDG uptake noted in bilateral lung fields. Also, the patient had multiple mediastinal nodes, namely the right lower paratracheal, subaortic, subcarinal, and right hilar regions. There were no other metastatic lesion anywhere. Patient was stage 4, T4, N2, M1A. Sir, and biopsy we did. Sir? Hello? Sir.
Continue.
Yes, sir. And the biopsy we did from the right lingular mass, we showed adenocarcinoma with a lipidic growth pattern. The NGS, the EGFR 19 deletion was positive, TP53 was mutated, and PDL1 was negative, sir, 0. So we planned for an EGFR targeted therapy with osimertinib, 80 milligram, if the patient is affording, or gefitinib, with palliative chemo, sir, with PIM cargo. So the question is, what's the implication of this EGFR and T53 mutations or in lipidic growth pattern? As such, lipidic pattern of adenocarcinoma is a favorable histology, but does the TP53 mutation imply a worse prognosis in this? And also, we are planning to start an osimertinib, sir. So, what do you think about the amivantamab as a first line, sir, in this patient?
Yeah.
Yes.
Can you show the reports?
Yes, sir. 72 slide will have the NGS. The next page is showed the TP53.
Next page has the EGFR and TP53.
TP53, yes, sir.
Next page, please. Yeah. That's the page. That's the page.
73.
73.
Yeah. So this is a classical exon 19 deletion. And there is also a TP53 with a pretty significant VAF of 48%, 47.5%. So, but I don't have an answer, or data to show how this mutation profile works or gives a prognosis in a lipidic growth kind of histology. So I don't have an answer to that. But otherwise, for this, I think FLAURA2 kind of a regimen should be the right approach in my thought. But it's a classical exon 19 deletion.
Okay, sir.
So, doctor, as Dr. Arun mentioned, there is no strong evidence to prove that the TP53 mutation, especially with the elliptic growth. Okay. And
Okay, sir.
because of that one, we cannot take into that consideration of connecting both a mutation with the elliptic growth and all. But when it comes to the plan of the EGFR exon 19 deletion, which is a classical one, so you have 2-3 options for this patient. Number one, as Dr. Arun mentioned, FLAURA2 clinical trial is present, which is osimertinib with chemotherapy. But there is now recently in the World Lung Cancer Conference games, is this patient have any brain mets actively right now?
No, sir, no.
No brain mets.
No,
So that
no,
means you
sir.
can start with a single agent of osimertinib if the disease burden is not very high. So that's what they have shown. If the disease burden in the higher side, in the subsequent later setting, you can add the chemo molecule into the picture. So FLAURA2 would be the better choice than amivantamab because the molecular nature, I will tell you, amivantamab is a monoclonal antibody. The EGFR exon 19 deletion is in the intracellular domain of the EGFR. When it is the intracellular domain mutation or the insertion deletion kind of thing, always TKI will work better. So the MARIPOSA trial is worked better because of the lazertinib combination. Lazertinib is the TKI which is mined internally. Whereas amivantamab combined with chemotherapy they have tried out, but EGFR exon 19 deletion TKI is always better than the just a monoclonal antibody which is amivantamab. So that's my personal opinion. That is the second option you are having, which is between MARIPOSA versus the FLAURA2. Then there is a one more interesting third option is there, which is the relay data. Relay data is the erlotinib with VEGF, which is the remibrutinib thing. That you can think about it later setting, not now. Currently, you can go ahead with the FLAURA trial or FLAURA2, whatever it is comfortable for you. And based on the thing, definitely Kripa Shankar sir will guide you better on that part of it. And then later you can think about is the relay data, which is the erlotinib. And afatinib is also having better study in the Lux data for the exon 19 deletion, basically. Depends upon the what kind of resistance mechanism it is going to develop in the next level. You can think about it in the later setting. Currently, FLAURA and FLAURA2 seems to be better option for this patient.
Sir, can you just tell again this intracellular domain? You're explaining why amivantamab doesn't work here. Can you just explain again?
And also the same thing, sir. Is always EGFR 19 mutation is an intracellular, or some of them will be an extracellular?
No, sir. Actually, whatever the exon 19 or exon 20 or exon 21, right? So all these things belongs to the intracellular domain of the EGFR, basically. Okay, so if you are imagining the amivantamab is a monoclonal antibody, which is almost like a cetuximab, like a monoclonal antibody. So whenever it comes to monoclonal antibody, either pertuzumab or amivantamab, or it is whatever the maps are coming, always it will bind to the extracellular domain. Like an antigen antibody reaction, it will bind to the extracellular domain. Whereas the EGFR exon 19 deletion is in the intracellular domain. Whenever intracellular domain is present, the TKI is working better because the TKI purpose is to bind to the intracellular domain, not in the intracellular domain. So osimertinib, afatinib, and then erlotinib, decoded, whatever the matinib is coming up, it is binding into the intracellular domain. Among the EGFR TKI, afatinib and osimertinib can have the better control of this particular variant, which is proven in the Lux data as well as in the FLAURA data. And erlotinib is also having good data, basically. So that's why we are telling that the TKI, which will bind to the intracellular domain, is better than the extracellular domain, which is the monoclonal antibody.
But I think,
Narendran. No, I think the MARIPOSA, the recent one which compared lazertinib plus amivantamab versus osimertinib upfront setting, there was a significant benefit with lazertinib plus amivantamab, right? Particularly when there is a co-mutation, P53 intracranial mets was there. There was a significant progression-free survival also was there, and trend towards overall survival also was there in this particular subset.
That's right, sir. I think, that was a head-on-head versus amivantamab plus lazertinib up against only osimertinib and not osi plus chemo, sir. And also the press release has shown that there is a more than 1 year improvement in overall survival as well, even though that data is still yet to be presented. But we know that has shown an OS benefit. But nevertheless, here I think the point that Silambarasan is trying to make is, like, for example, when we have HER2 overexpression versus HER2 mutation. HER2 overexpression, we know all these MABs act on the extracellular binding domain. Whereas when you have a HER2 mutation, your trastuzumab is not going to work, which is why we look at using small molecule inhibitors, because the intracellular signaling pathways have to be blocked. So I think that is the point in general that which Silambarasan is trying to make here, as a learning point, a difference between TKIs versus MABs as far as, patients who have...
But in amivantamab, we are combining with lazertinib, right?
That's right, sir. That's right. So
it is going to take care of...
Absolutely,
if you are combining with lazertinib, that is the best molecule. Amivantamab combining with the lazertinib is the best. Here, if you are not combining with the lazertinib, it's a question mark. If you are not going to combining with the lazertinib, better to go for FLAURA.
Yeah, so I think that is just as a learning point as to, between MABs versus TKIs in general, and not particularly for EGFR mutations, and that too with a co-mutation having 2EP53 as well. So here, if you look at the FLAURA2 data as well, where they looked at patients who have co-mutations, they also seem to benefit. So here, I think the volume of disease matters. If I can ask the presenter, what is the volume or burden of disease here?
Sir, the primary disease is 4.2 into 3.5 centimeter lesion, sir. There are multiple bilateral lung nodules are present, sir. Around size of 10 mm, sir. 10 mm to 9 mm multiple nodes, and the mediastinal lymph nodes are present. Larger size is only 1.2 centimeters, sir.
It's primarily only thoracic disease, nowhere else. No brain.
No, sir. No, sir. No, sir. No, sir. No, sir.
Okay. So it's not a large volume of disease. Okay, so that's fine. But nevertheless, having said that, when you have a TP53 co-mutation, irrespective of the histology, whether it's a lipidic pattern, they tend to have a slightly worse prognosis. So it tells you that it's an aggressive biology and they are likely to develop resistance as well. And that it portends for a worse prognosis. So here, that you can absolutely go ahead and do OC plus chemotherapy here if the patient is fit enough for the same. So your patient, I believe, is fit and in good general condition.
Yes, sir.
Yeah. So and as far as this debate between OC plus chemo versus amivantamab plus lazertinib, they're only based on cross-trial comparisons. There is no head-on-head between OC plus chemo versus amivantamab plus lazertinib. We only know that ami plus lazertinib is better than osimertinib, but not OC plus chemotherapy. Right? Okay. And again, when we talk about high risk factors, remember co-mutations, brain metastasis, large volume of disease, and ctDNA being high at baseline. So these were the high risk factors where you would look at using a doublet and not just use your single agent TKIs. And as far as whatever Silambarasan was saying, ramucirumab plus erlotinib or erlotinib plus bevacizumab based on the relay and then the NEJ studies and all of that, I think none of them have been able to show an improvement in overall survival yet. So that's all based on PFS benefit. And, another criticism of the relay data is they excluded patients with brain metastasis. They did not include them as well. So the intracranial efficacy of ramucirumab plus erlotinib is a question mark. We don't know because those patients were excluded from that trial. So here, I think your best option would be OC plus chemotherapy would be my choice as well. I would agree with your decision of having to go with OC plus chemotherapy.
Okay, thanks.
Krupa sir, one curious question. Will you consider any ctDNA for this patient?
See, if you look at all the data and all the subgroup analysis that have been published as well, Simbo, based on either from the MARIPOSA or the FLAURA2, they have looked at tracking the ctDNA levels and seeing how that correlates with the treatment efficacy.
Correct, exactly. For that purpose only I'm asking, sir. For the treatment efficacy to monitor, will you consider ctDNA testing for this patient?
In fact, that is actually being done as part of, if you look at RGCI, Dr. Ullas Batra has already for EGFR mutations also. They track the as well as far as is concerned. So it is interesting. You can do that provided, your patient is driven and, financially well off, not financial constraints, will be able to stick on to it. Yes, definitely worthwhile.
Correct.
how they are
So
going to.
if the patient is affordable, it is worth it to follow with the ctDNA, which will tell that whether the treatment efficacy is working very well or not in the well advanced setting.
Absolutely.
Yes. Thank you, sir. Thank you so much.
Pleasure, sir.
Just a point regarding this confusion. So we know that any atypical EGFR mutation or exon 21 insertion, we suggest amivantamab. But this concept of when there is a cellular domain kinase mutation, is that amivantamab may not work well. So that doesn't hold, right? Because any atypical mutation or any resistant mutation, we just still suggest amivantamab there.
So, Dr. Narendran, it is because TKI domain where the small molecule binds, the new mutation prevents a small molecule from binding. So that's a resistance mutation. At that point of time, you don't have any other way to target or inhibit the tyrosine kinase, the domain, tyrosine kinase domain. That's where you go for...
Amivantamab will work there.
Amivantamab will work. Amivantamab works even in EGFR exon 19 deletion, simply put. No doubt about it. But
yeah,
the efficacy will be much better when you're able to inhibit the tyrosine kinase directly. So when you have an option to stop the protein activity directly, because the enzyme activity, tyrosine kinase activity, it is preferred to do that. That's the essence of this. But now when you have an exon 20 insertion, or when you have an exon 20 mutation where the efficacy of your third generation TKI is limited, you go for an amivantamab, which prevents the EGFR activity by binding it to the external extracellular domain, where I think in one arm of the antibody it binds to EGFR, the other it binds to MET. So
okay.
MET. So it prevents EGFR. So for EGFR to activate, you need two nearby EGFRs to come together and bind. So it prevents that, and hence, irrespective of whether the EGFR is having a mutation or not, all EGFRs would be inhibited.
So blindly, like what we talk in HER2 receptor, we cannot hold that concept here. That's what I wanted to emphasize here.
Absolutely correct, Naren. So,
yes.
HER2 is different because, HER2 doesn't need a ligand for activation. It's an already activated receptor. So that's the key difference here.
So HER2 is different, EGFR2 is different. So EGFR is different. I want to emphasize that. So that wanted to.
EGFR receptor is different from EGFR mutation. EGFR is nothing but HER1. If you look at it, that's when the HER family of receptors. HER1 is called EGFR. HER2 is what we actually target. HER2, HER3, and HER4. So the EGFR receptor is slightly different from, like we talk about expression versus overexpression, amplification, and mutation. That's the key difference here, Narendran. And also amivantamab is slightly different as far as the other MABs are concerned. It's a bispecific antibody. So it not only replies on that, it has ADCC, CDC, and antibody-dependent cell-mediated phagocytosis as well, ADCP as well. So,
Kripa, my only one thing is, just because we don't have a data, amivantamab plus lazertinib versus osimertinib plus chemo, is the only reason why we are not giving that as one of the recommendation in this particular case?
Not only, sir. I mean, like, if you look at the lazertinib data, sir, the treatment discontinuation rates because of toxicity was 35%. 1/3 of patients had to discontinue because of toxicity. 65% had infusion reactions. And I'm talking about grade 3. So, that.
But still, if you see it as like, I think hazard ratio is 0.6, I think 40. With that also.
Even the same hazard you're getting with Aussie plus chemo also, sir. So there is no way you can say Aussie plus chemo is inferior, or you could say Ami plus.
But if you see the FLORA trial, the P53 particular subset was doing pretty worse actually with osimertinib. That is
plus chemo. Talking about Aussie plus chemo, the FLORA 2 data, P53 patients with co-mutations also did benefit. That was a subgroup analysis. So my only problem is, and let me tell you that, sir, I've used Ami plus lazertinib right upfront also. For the first 4 months, patient has got to be on anticoagulation as well. Because the risk of DVT is again around, again on the trial, about 1/3 of patients had DVT also. So I think
based on the personal experience and side effect profile, probably we all are like, even I haven't used it. Like,
also, sir, the absence of head-to-head trial showing that Ami plus lazertinib is better than Aussie plus chemo. We don't have that data. So, so to me, both are equivalent options. albeit the side effect profile much lesser and financial toxicity much lesser. With the AMI plus lazertinib, we don't have lazertinib available in India.
Probably that should be mentioned in the recommendation, like why we are not for amivantinib plus lazertinib despite the MARIPOSA, whatever the data we have. Probably that's why I think real world scenario, all of us go for OC plus chemo. That's it, because of whatever Kripa is telling.
Arun sir, just 1 minute. Arun sir, if you are looking at that chat, I have put it out. Even the P53 positive, the FLARA2 data, the hazard ratio is very good only. So
Correct,
that means the P53 co-mutation can be taken care by the FLARA2.
No. But if you take the MARIPOSA trial, if you see the P53 subset alone, they had more benefit. If you see that it was 60%, like hazard ratio was 0.6. The overall population was 0.72, I think. But if you see the P53, they benefited more with amivantinib plus lazertinib.
I agree, sir. Like Dr. Kripashankar is saying, it's not worth of trying because of the toxicity.
So it's a toxicity, that is why most of us are worried. It's not about the
efficacy.
Yeah.
About toxicity, both financial as well, sir.
Finance.
I do.
Yes.
Yeah. And probably we'll look out on an effective sequencing strategy as well, because at progression also we know AMI plus chemo or AMI plus lazertinib is a good option, whereas we don't have the data to do that in second line.
Absolutely.
So those are all valid points, sir, because of the toxicity and in terms of both adverse events and also in terms of financial toxicity. For this patient, osimertinib plus chemotherapy looks to be an optimal option. Naren, can you summarize?
Yeah, you are summarized, sir. So same. Teja, you are summarized, Teja. So we can go ahead. Next case.
Yeah. So we'll go to the next presentation, Dr. Ramakrishna from Meenakshi Mission Hospital.
Good evening, sir. I am Dr. Ramakrishnan, first year resident from Meenakshi Mission Hospital. So my case for today, next slide, please. My case for today is a 53-year-old female. She was diagnosed with metastatic CA breast in 2021. She is a known diabetic. She has a family history of colon cancer, which was diagnosed with her mother. Next slide. She was diagnosed initially. She was diagnosed with metastatic breast cancer. ERPR was positive, HER2 negative. So she received 6 cycles of palliative chemotherapy with pyriproxine cyclophosphamide, after which she had a pretty much good response. So since 2022, she was on ribociclib plus letrozole. So last PET scan in August 2025 we took, which showed no active metabolic lesions. Pelvis alone showed an hypo-enhancing nodule on right side without any significant uptake, and tumor markers were within normal limits. So she had the patient had a doubt of clinical family history of colon cancer. So whether she needs to underwent any family screening. So we did an hereditary gene panel. Can you show me the NGS report? Next slide, please. We did a hereditary gene panel which showed a RAD51C exon 3 mutation, heterozygous mutations of a variant of uncertain significance, and similar VUS in CHEK2 exon 11 mutations, heterozygous. So my question for this panel is whether these 2 mutations will change any treatment modifications, or to answer the patient's questions of whether she needs any family screening or any other member of the family should be screened for breast cancer or colon cancer in this case.
Can I take this query?
Yes, sir. Genetic counseling person will be the right person. Yes, please.
Yes, thank you. So thank you for this case. So there are a couple of things I would like to just bring your attention to. One is the cancer panel covers the SNVs, which is your single nucleotide variants. And I see that the deletion duplication has not been seen. So considering the family history, I would like that to be covered as well. So if they are affordable, they can repeat this as a comprehensive gene panel alongside the MLPA to be tested. Otherwise, you can also opt for a digital MLPA, which is again, it is just a dry lab work. You don't have to repeat sample. So that is the first thing. Second thing is both are reported variants, but unfortunately they're uncertain in significance because there's no strong evidence with their association with HBOC or hereditary cancer disposition. but both of them
Yeah.
are moderately penetrating genes for disposition, hereditary disposition. So considering that and the fact that there is in the vicinity of these reported variants, there, at least for RAD51, there are pathogenic variants reported. So considering that, I would suggest, if the mother is alive and willing, to cross-check these two variants in the affected mother with the colon cancer, and then consider reclassification, and based on that proceed for screening for other family members, especially first degree.
Okay, ma'am. What about this particular patient? Any particular follow-up is necessary, or we can continue the same treatment as we can continue ribociclib and letrozole. Right now we are continuing ribociclib and letrozole.
Treatment, I think the other experts can pitch in, please.
Sir, when it comes to treatment, this both mutation mentioned over here is a VUS category. So based on that VUS category, we cannot take any clinical decision. Okay, but what we can do is the treatment is not going to change. That's a one-line answer for the same thing. The treatment is not going to change because of the VUS mutation. What we could do is, this is done in the blood, which is the hereditary gene panel. So you can go back to the tissue block sample to prove that whether this VUS mutation is also present in the somatic level, which is in the tissue level testing. Then, as Dr. Brinda mentioned, go back to the mother's blood sample to prove that this is running through the family. So first is somatic testing to prove that the VUS mutation can potentially a pathogenic, likely pathogenic, not pathogenic, likely pathogenic mutation. Then cascade testing with the mother in the hereditary gene panel of the blood. Then we can consider, not immediately prove, we can consider this mutation could potentially align with the family history of cancer. Then only we can test for the other family members. So, but the treatment wise, we cannot do any treatment with the VUS mutation. That's it.
I just want to ask Dr. Kripa here, sir, do you know if this functional HRD is available in India? Because this patient particularly has RAD51 and functional HRD looks at RAD51, the activity of it.
So currently right now, sir, Tempus is able to outsource it. So I think we can get in touch with them. They'll be able to help us with it as far as the functional HRD testing is concerned.
Okay. Yeah.
So, but it's proven in ovary, right? Still, we can do it in breast also. You want to do it here also?
No. If it is just that was just for an academic discussion.
Academic,
which Dr. Arun sir wanted to know. That was it. I'm not going to suggest doing a functional HRD here, but nevertheless, the patient really wants to know about if the patient has exhausted all lines of options, like we keep talking about, Naren, and probably you're left with nothing better to offer. At that point in time, yes, you could definitely look at contemplating a functional HRD to see if that will translate into therapeutic potential.
Okay. Yeah,
but one thing, Kripa,
yes,
we see with all the HRD and ovary PARP inhibitors, we know these CHEK2 and RAD did not have much benefit actually. So even if you get this in other cancer also, you see only few HRR had really benefited with PARP inhibitors when we used it.
Again, sir, that is based on FDA meta-analysis in prostate cancer. That's the data that you're quoting right now, sir.
Correct. No, prostate. Yeah, mostly prostate. Correct.
Exactly, sir. Majority of them are prostate, and ATM and CHEK2 also. Exactly, sir. But I'll tell you the criticisms about that, sir. If you look at, they concluded that even ATM and CHEK2 did not seem to benefit. But if you look at cohort A, which is the primary endpoint on the PROPEL data, which led to the approval of olaparib initially. So if you look at it, cohort A had ATM also.
No, but the problem with ATM is it's a large gene, so they don't know which all mutations. So it's too difficult for them to understand which mutations is translating into benefit because it's quite a large gene.
Absolutely, sir. Which is why functional HRD means it's real time. Meaning, you're not worried about the cost. You're not just looking at the DNA damage repair genes or the HRR pathway alone. You're seeing if that actually translates into a genomic instability score or a genomic scar score, or the genomic aberration signature, as has been reported nowadays, GAS score. So we're actually looking at whether this translates into it as real time. For example, if there is any site DNA damage, we know that these PARP proteins have to get localized to the site of DNA damage. For example, RAD51C. So depending on whether they're actually getting localized to the site of the DNA damage is what functional HRD is all about. So functional HRD is probably like real-time HRD, which will tell us, okay, fine, it is translating into HRD. So this patient is likely to benefit.
Yeah.
Just like how we talk about platinum sensitivity.
No.
So I think yes. And as far as all the other genes, like for example, PAL-B2, ATM, now we have the data even in breast cancer for PAL-B2 also, where even risk reduction strategies are being spoken about, just like BRCA1 and 2. So I think, moving forward.
This ASCO, I think PAL-B2, they almost like BRCA1 and BRCA2, they are treating. The recent ASCO, if you see the genomic ASCO podcast and the whatever the guidelines, it's almost treated like BRCA1 and BRCA2 as far as the PAL-B2 is concerned.
Even the current Sen-Gallen recommendation also, sir. This current Sen-Gallen recommendation, which is read just, they've also concluded that PAL-B2 is more like BRCA. So I think we are getting to that BRCA-ness or BRCA-like as far as, all of these mutations that are involved in the DNA damage repair are concerned. But RAD51C, definitely yes. CHEK2, not so much, because, they didn't seem to benefit much as far as the pooled meta-analysis that you're talking about. ATM and CHEK2 didn't seem to benefit much, but PAL-B2 and CDK12, if you look at all of that meta-analysis, but again, the criticisms there where the numbers were too small, sir, for us to draw any meaningful, conclusions from that meta-analysis. So probably, moving forward, we'll need larger numbers for us to be able to translate this into clinical practice. Until then, I think HRD is one way in which we know whether it's actually translating into the cost translating into an effect.
So for family, for the question asked, so what is the suggestion, sir, to check for the mother also whether the same mutation is running, and if it's for the mother also, if it's uncertain significance, what we are going to say then?
Get it into the database and make sure that we follow it up. I think that's one way. Because today's VUS can be tomorrow's pathogenic.
So should we check for if mother is also having the same mutation as uncertain significance? Should we check for other family members, siblings also same mutation?
First degree.
I don't think that would be recommended based on a VUS. So we should wait until it is reclassified as a likely pathogenic or a pathogenic variant.
Agree.
So
suppose if the mother is classified as pathogenic, what will be your suggestion, ma'am? Suppose the CHEK2 mother is classified as pathogenic, then we take this as a pathogenic, same variant.
The classification is not dependent on whom is tested, rather than it's the variant that is being tested. So in this case, if it is reclassified, it will be reclassified for both the mother and the daughter. And the database.
And also, sir, the NCCN guidelines right now, for the germline mutation, it is mentioned that if any VUS variant is there, no action to be taken, or you should not go for a further testing for the family member.
Agreed.
So in this case, Dr. Narendran, I would suggest just cross-check the deletion duplication once before, or do a complete hereditary panel for both of them. That is also an option where you include the SNV and indels.
So is there any recommendation to do complete hereditary? How much gene panel? Is there anything you suggest here?
The same lab has the option, doctor.
Comprehensive genome.
They have a comprehensive genomic panel, a hereditary gene panel. Otherwise, you can add on a digital MLPA.
Yes, MLPA also will add on here.
Okay. So for a question to the for the present task question to check for the hereditary comprehensive germline cancer panel for the patient, and also to reach whether the same it's running through for the mother, and then decide whether it's significant. If both are uncertain significance, and then to register to wait for whether it is being reclassified as pathogenic in the future. So for the treatment purpose, as of now, based on the this report, we are not suggesting any treatment, and the patient is not progressed also. So to continue the same line of treatment, suppose if all the lines are exhausted, maybe in the future they can repeat the biopsy. In that biopsy, they can check either functional HRD or HRD. If it is positive, they may consider a platinum-based therapy. Either that can be for treatment.
Yeah, but as of right now, no therapeutic implications. That would be the bottom line. Correct.
Yeah.
Okay, sir. Thank you. Thank you.
So next, I would like to call Dr. Jerin from Asterbeam's Polycode.
Good evening, sirs. So I'm presenting a case of a 64-year-old male who's without any comorbidities, a fit man. He was evaluated for a pain in his upper thigh region, and it was found to be a lytic lesion, and a PET imaging showed a primary in the lung. We took an EBUS-guided biopsy. It came back as a poorly differentiated carcinoma. When we did the IHC also, it was pretty inconclusive. The small cell carcinoma markers were positive without the morphology of it, as well as TTF1 was positive. And then we also asked for a genomic panel. We started him on gemcitabine and carboplatin because we did not have a definite evidence of adenocarcinoma. And while waiting for the NGS, we found the following reports. If you could share the NGS report, please. There was an exon 19 deletion mutation along with a MET amplification, but there is also a VAF of 23% in an exon 19 of EGFR. Exon 20 of EGFR, the variant allele frequency is higher for the exon 20 mutation. There is an exon 19 deletion mutation, which is tier 1, which is pathogenic. There is a MET amplification, which is also tier 1, which is pathogenic. So how do we go about this mutation? We started him on chemotherapy already. Can we give osimertinib given the high frequency EGFR exon 20? Does it work? Should we go for an amivantamab based therapy because there is MET as well as EGFR concurrent mutations?
Before going for any pathologist there to comment, because the TTF is positive and synaptophysin also positive, whether it's a large cell, whether large cell.
I think we have
Or
Dr. Madam. She's joined us. Dr. Chandra ma'am, are you there?
Yes, sir. So good evening. Sir, TTF1 synaptophysin. Synaptophysin actually it is got a huge amount of sensitivity, but specificity for neuroendocrine carcinoma is very, very less for synaptophysin. So with that positivity, I don't think we should consider the possibility of a neuroendocrine carcinoma large cell. And moreover, large cell, small cell, all those things come in the histology. So if the report is adenocarcinoma TTF1 positive, I think we need to take it as adenocarcinoma only and ignore the synaptophysin alone.
Perfect.
Thank you.
No, Madam, only one thing is that K is 67. I think what was the K 67 here?
So we did not do a Chi67 here, sir.
Oh, okay. Thank you.
The morphology did not look like neuroendocrine. That was what the pathologist said.
Yeah.
Okay.
In which case, the synaptophysin should be ignored. Thank you.
Thank you, ma'am.
Thank you. So I think your question being, what was your question? I didn't get.
Sir, could you see the VAF, sir, of all the mutations, sir?
Can you just come down?
Can you next slide?
Sir,
Next.
I think. Yes, this one, sir. So there is an exon 20 mutation with a VAF of 23%. There is an exon 19 mutation. There is a MET amplification. So what is this exon EGFR exon 20 mutation? How is it significant, sir?
Yeah. So this EGFR exon 20, this L792 phenylalanine, this is a resistance mechanism for osimertinib, known resistance mechanism. But generally, this particular EGFR L792F comes along with C797S or other exon 20 mutations. So you look for the orientation, whether it's a cis or a trans. But in this case, that is not possible. This is an exon 19 deletion and exon 20 mutation. So this could be a very, and the VAF is also highest for this exon 20 mutation. And given that there is also a MET amplification, I'm not sure of the copy number. I don't know if it's mentioned anywhere else. I think a better strategy here would be to use the bispecific amivantamab. But I leave it for others to comment. And please note, it's a pretty bad. There is also a HER2 mutation here with a 5.8% VAF. So I'm more inclined towards amivantamab at this stage.
Yeah, so agreed. I think here, if you look at it, your EGFR exon 19 activating deletion, that's a mutation. EGFR exon 20 is a missense mutation. And that's probably, I mean, like, described as a resistance mechanism to osimertinib and a known resistance site to osimertinib. MET amplification, copy number gain. Has that been mentioned? Because usually we look at a copy number cutoff of at least more than 10.
10 and above.
So it'll be interesting to see that. And there is a P53 as well, a frame shift, loss of function mutation that's also been picked up here. So I think here, if your patient has got no financial constraints, here amivantamab would be a great
Correct.
Ami plus lazertinib would be a great option for you to go up front, first line, if your patient has got no financial constraints. But if your patient has got financial constraints, then you go the far away, meaning do OC plus chemotherapy.
Can afatinib be used here, sir, for that EGFR 20 mutation?
See, afatinib, the data is more towards atypical mutations as well. But here it's more or less like a co-mutation. So I don't think afatinib alone will help you as far as the MET and also as far as the TP53 co-mutation is concerned. So it has to be a combination of both. I mean, I believe a combination strategy would be better here rather than doing only afatinib monotherapy. So if cost is not a constraint, lazertinib, number one choice. Number two would be OC plus chemotherapy here. If your patient can afford amivantamab, then I think you could do OC plus chemo.
Okay, sir.
Actually, it's nice that we had two cases. Okay, so one case where we won't work because of the toxicity and profile. This case, I think, as Kripa said, I think because of the MET, we don't have a choice. So that is better as a first recommendation rather than going for OC plus chemo.
Yes, so totally two different contrasting cases, but one we are preferring the other combination, and here we are preferring. So totally very interesting case. Very interesting case.
Very interesting. Nice case. It's a learning case. Thank you.
So is there any combination of MET inhibitor along with EGFR? Anyone, like for example, if the patient cannot afford amivantamab, in that situation, if osimertinib plus MET inhibitor plus chemotherapy can be given for this patient?
Sir, that's what Dr. Krupashankar sir mentioned, or Arun sir mentioned. I don't remember who is mentioned. We need to know the MET amplification copy number. If the copy number is not that great, basically, chemo molecule can be able to take care of that copy number, basically. So we need not to add one more MET inhibitor into the picture. If the copy number is not that great high, we don't know what is the copy number over here. So for that perspective, benefit of the doubt, as Dr. Krupashankar sir mentioned, amivantamab with lazertinib is the best choice for this patient in the beginning itself.
Yes, sir. Currently, we are not having access for lazertinib. So in that situation, then osimertinib plus chemotherapy.
Yes, Silamarasan, his point is, can I add some MET inhibitors like trametinib or something along with osimertinib to bypass the MET amplification is the question.
We don't have much evidence, sir. We don't have much evidence, to be very honest.
Okay.
Like crizotinib, tepotinib, like that we are asking, right? So we don't have much evidence to combine EGFR TKI with that MET inhibitor, basically.
Like we are combining dabrafenib plus trametinib, right? Something like that. Why not osimertinib plus? So that's a very good question. Yeah,
but we don't have evidence.
We don't have data. We don't have data.
Yeah, interestingly, there is data in the second line setting to do that. So there is OC plus, even savolitinib or OC plus tepotinib, inside data. The trial is called Insight. So there is data that to that effect in the second line where you could combine, EGFR TKI plus a MET inhibitor, but it's not yet currently FDA approved. It's not yet.
It's not even it's not yet matured, sir. The data is not yet matured, if I'm not wrong. Inside trial data.
It has shown a BFS benefit, but the primary endpoint is BFS. So the overall survival is still not yet mature, and it's not yet FDA approved. Doesn't have a level 1 recommendation anywhere. But nevertheless, I think definitely a worthwhile strategy, especially in the second line setting, when somebody goes on and develops a MET amplification as a resistance mechanism. But which is why probably even if the patient has not been exposed to amivantamab by then, I think amivantamab would also be an option then. even if your patient has developed a MET amplification later in the second line setting, if you've not used amivantamab upfront. But if you've used it upfront, then, we don't know what the efficacy of this combination will be in the second line. Because because only recently AMI plus lazertinib has been approved in the first line. So we don't have the data as to what happens when somebody progresses on that combination. What can you do in the second line? Will OSI be effective post amivantamab? We don't have that data. We only have data to show that AMI is effective for patients who have progressed on osimertinib.
Yeah.
Great.
I just have a point here, Dr. Kripa. This particular mutation, the exon 20 mutation, is a known resistance mechanism to OSI.
That's right.
So are we still leaning towards giving OSI here?
So I think unfortunately that's the best of the options that we have. Third generation EGFR TKIs, fourth generation EGFR TKIs are still in the pipeline, meaning they're in trials, the Blue 6 trial as well. But nevertheless, we have other TKIs like omalatinib, pomatinib. All of them are other third generation EGFR TKIs with variable effect, especially on the PAC mutations or the alpha C helix and compressing type of mutations that can also happen with EGFR. But nevertheless, those are not available in India. Those are all Chinese molecules. Again, omalatinib and pomatinib seem to be leading the race as far as that is concerned, like lazertinib as well. So I think given that with the potential caveat that we know it's a resistance mechanism, OSI plus chemotherapy, if the patient can't afford or cannot access AMI plus lazertinib, would be a second best choice, if I might put it that way.
Kripa sir, actually, if I'm not wrong, Dr. Arun, where he is coming from is, it's not the resistance mechanism is because of the acquired resistance mechanism kind of thing. Here, this particular mutation, what we are referring here, it will not allow even osimertinib, the binding pocket, to bind. So
Exactly.
that means osimertinib cannot bind properly.
Correct. So that's what that's what I meant by even PAC mutations also. So the P loop and alpha C helix compressing mutations, which is all again, that binding site is different. The ATP binding site is different for all of these types of mutations. We don't have any data to show that one TKI is better than the other in these particular rare or atypical mutations. And especially this happens as a co-mutation, meaning it's not it's one of those mutations that go hand in hand with either an exon 19 or an exon 21 L8 FATR. So this doesn't usually happen alone as a standalone event, like a driver.
Sir, one more clarification. Basically, in this case, if we are considering the MET amplification is not very significant, can we think about afatinib?
So again, afatinib alone, the data for doing that, when you have...
Not definitely alone, but I'm thinking that instead of one TKI, afatinib, how is the efficacy in this exon 20 deletions? Mutation.
So that's what, again, we don't have the data to combine afatinib plus chemotherapy. Unfortunately, we don't have that data. So the only data that we have right now is either geftinib plus chemotherapy or osimertinib plus chemotherapy. So of the two, if you had to choose between a combination, where I believe a combination would be better than doing just a single agent TKI. And afatinib, so I think hence the rationale for saying that as a second option, if AMI plus lazertinib is ruled out, then OSI plus chemotherapy would be an option.
So last question. Sorry, I'm taking a bit time here. FLAURA2 versus Papillon, right? What do you suggest here?
As far as exon 20, because Papillon is for exon 20
insertion. But this is an exon 20 mutation.
Correct. So exon 20 insertion, I think clearly AMI plus chemotherapy is the clear winner. I think OSI doesn't work in exon 20 insertions. So I think their clear winner is amivantamab plus chemotherapy. You don't even need lazertinib there. It's only AMI plus chemotherapy in the first line setting based on the Papillon data for exon 20 insertion. I think this debate is more of for the exon 19 and 21 L8 FATR or the exon 19 deletions that we get to see more common. The common activating EGFR mutations, as we would call them, sir. So I think that's where the debate is still on. But I think as far as both the toxicity and the sequencing options are concerned, I think in India, where we still don't have access to lazertinib, I think fair enough to say OSI plus chemotherapy is a good enough option, given that we now have the overall survival data as well for OSI plus chemotherapy. Has shown an improvement in overall survival, 47 versus 37 months. Absolute improvement of close to 10 months in overall survival for the combination as opposed to single agent osimertinib. And again, if you're looking
But
at all
if the
these atypical mutations also, there is data for, called a unicorn study, which looked at all these atypical mutations and response to osimertinib. They've even looked at going up on the dosing of osimertinib to 160 milligrams also, just like how we talk about the geotag for afatinib real world data in atypical or uncommon mutations. There is data to the same effect with osimertinib as well, based on a unicorn study. So I think it's just a question of that a third generation EGFR combination therapy here would be a better option. My 2 cents.
But the osimertinib is also very costly. Then why you give when we know that there is resistance?
Sorry,
this drug also.
Pardon? I didn't get you.
When osimertinib is also a costly drug. In a financial context, it said then why to use this drug when there are chances of resistance is there?
Yeah, so the problem is when compared to amivantamab plus lazertinib, osimertinib is not more expensive. So I think that is where that is the point that I was
Of course, that you can say, but
exactly.
But,
so I think
this is also very costly, right? Osimertinib is also.
Osimertinib is expensive if you're using the original molecule, but then that, I don't want to get into that debate as to whether you should use the original molecule or you should use the ones that are imported from Laos, Vietnam, or Bangladesh. We're not going to get into that debate. But nevertheless, I think, as far as cost constraints, if your patient can't afford, the original molecule, I've had no issues about offering them the other osimertinib as well, albeit procuring it the other way. And again, like I said, afatinib versus osimertinib in uncommon mutations, there is no head-on-head to show that afatinib is better. Only thing is, we don't have the data to combine afatinib plus chemotherapy, whereas we have the data to combine osi plus chemotherapy, and that has shown an improvement in OS benefit as well. So again, as far as this resistance mechanism is concerned, we are not sure as to whether all of those patients will go on to develop resistance. So it's like saying, it's a poor prognostic indicator. That's it. But, you cannot say that osimertinib will not work here.
Kripa sir, actually, Kripa sir, sorry to take you lengthy. Actually, along the line of Dr. Arun points, actually, there are a few case reports are showing that amivantamab can able to handle this, especially this particular mutation. There are few case reports who are progressed from osimertinib kind of treatment. Actually, there are case reports. Just now, while I am going through, there are certain reports are there. So right now, will you consider amivantamab with chemotherapy or osimertinib, which is here this particular mutation, have the resistance mechanism even to bind the osimertinib? So osimertinib with chemo or amivantamab with chemo?
So I think let me clarify again, Simbu. I think my first choice was Ami plus lazertinib.
Not lazertinib, sir. Not lazertinib, sir. Not lazertinib. Lazertinib is not available.
I think
my question is amivantamab with chemo.
Amivantamab plus chemotherapy, unfortunately, in the first line setting for EGFR exon 19 deletions is not the option. That is only in later lines where we do second line.
Yes, sir, totally I agree. Because totally I agree, sir. Because if it is only exon 19 deletion, yes, I agree. But here the question for me is because of the exon 20 point mutation, which is known to cause the osimertinib resistance. Whereas that is what I am considering or thinking about amivantamab with chemo.
Correct. Yeah, so I think, rather than do that, if somebody can afford amivantamab, I think they'll be able to afford getting lazertinib also. I think that is my way of looking at it. So if somebody, can shell out 6 lakhs for amivantamab per month, I think they wouldn't mind, getting lazertinib also. So I think that's my point of having to choose between both.
No, sir. If the cost is the point, then we are out, sir. Totally out.
Yeah, so I think that's the only thing about this thing.
I think we spend more time in this particular case. Probably consensus, we can finally do it. I think. What is the final consensus? We'll just make it so that we can go to the next case.
The final consensus, the final consensus is amivantamab plus lazertinib. If a patient cannot afford that, osimertinib plus chemotherapy.
Okay, fair enough. So next I'll call upon Dr. Isha from KGMU, Uttar Pradesh.
Good evening, everybody. So can you please show the slide? So I wanted to discuss this case. Actually, this patient was referred to me from some other center. So only the information that I have, I've shared. A 71-year-old male with a squamous cell carcinoma of the left lower lobe of lung, the stage 4 at diagnosis. The date of the biopsy is 30th of September 2024, which showed a P40 positivity with a TTF1 negativity. Hello. And initial PS was 2. And currently, the attendant had come with the reports of this patient for a second opinion. So, as per the current performance status, I only know that the patient is doing well. So, we can take it as a PS of 1 maybe. But there's definite progression on the imaging, on the CT scans. Patient was given 6 cycles of Paclitaxel and Carbo till April 2025, from September or October 2024 till April 2025, after which patient received 14 doses of pembrolizumab. And so I just wanted to discuss this case in the virtual MTB because of the NGS report which was shared with me. Can you please show the NGS report? So the patient has a tier 2 pathogenic mutation of ALK TP53 and HER2.
Next slide. Next slide.
Next slide. And the VAF for TP53 seems to be the highest, but patient also has ALK and HER2 mutations, all of which have been reported to be tier 2 and likely pathogenic. So what is everybody's opinion on this case? How to proceed if there's a progression documented on imaging after 14 doses of pembrolizumab?
Ma'am, regarding this mutation, basically, the ALK mutation which you are mentioning here, right, V1180F, actually it's a kind of little bit of evidence are there. It is a resistance mechanism to alectinib, basically. So I will share that some of the small evidence, but it will be useful. There is a heat map chart will be there. So in this case, I feel brigatinib would be a better choice for this patient. Certinib data is there a little bit here and there, but there is not specific to this particular mutation, but brigatinib have some evidences are available. So
Silambarasan,
yes, sir.
sorry to interrupt you, very sorry to interrupt you, but this was never proven to be ALK fusion positive. Was it ALK fusion positive?
No problem. This was only
There's no mention of that. Can you show the other?
I saw only chemotherapy in the first line.
Correct.
Dr. Arun,
Patient has received only chemotherapy in the first line. Yes.
And also, this is a squamous cell carcinoma.
This is a squamous cell.
Yeah, this is the squamous.
Dr. Arun, I was trying to mention the binding capacity of the ALK TKIs, not suggesting any treatment. I'm not suggesting any treatment. That is purely the call of Dr. Kirubashankar sir and other people. What I'm trying to say is the ALK TKI binding capacity wise, alectinib don't have the binding capacity more over here, basically, when compared to brigatinib or certinib. Any other drugs cannot able to bind properly because of this particular mutation. Because this kind of mutation, generally, we will see only after the particular ALK TKI as a resistance mechanism. But here, generally, we are seeing in the upfront. So I don't know the how the treatment efficacy and all, but binding capacity wise, the drug efficacy will be reduced. That's all I'm trying to say. No treatment and all here.
So for this patient, I don't think we have baseline NGS.
Correct.
No, but RNA sequencing is done here. I'm not sure why it did not pick up the ALK fusion, if at all it was ALK fusion positive. Generally, as Dr. Silambarasan rightly said, you get this mutation only upon as a resistance mechanism to ALK-directed therapies. So my submission would be try doing one ALK fish. I'm sorry, not fish. IHC if possible. But otherwise, this is not a targetable alteration. If without a ALK fusion positive, you cannot give any ALK inhibitor targeting this point mutation.
Correct.
Or There may be chances where the fusion partner has not been detected here. So that's also we have to find out. In NGS, based on the breakpoint region, in the bioinformatics, I think they will be able to find it out. Suppose if the lab is able to do it.
But RNA sequencing was done, so irrespective of the fusion partner, they would get reads of the fusion partner. So if it was DNA, yes, what you say is very correct. But for RNA, when they have done RNA fusion testing, even if it's a novel transcript, they should be able to pick it up.
I agree.
This biopsy, this NGS is done from the biopsy which is at the time of diagnosis, or repeat biopsy is done, ma'am?
No, there's no, the patient's attendant told that there was no repeat biopsy done.
So
So
this
this is the
biopsy
same
is from the
sample.
baseline biopsy.
This is the same biopsy, yes.
Oh,
Okay. So perfect. I think the HER2 mutation also here, you could probably look at targeting that with TDX.
Yes.
Yeah, so that's an option because unfortunately in the
TDXT.
in the absence of ALK fusion, this is not a targetable ALK mutation. Especially when you don't have a fusion that's been picked up, either the EML4 ALK fusion or the other rare fusion transcripts that have been reported. Unfortunately, none of them picked up. Whereas this HER2 mutation is actually a activating HER2 kinase domain mutation. And it's been reported in adenocarcinomas, but very rare to have it in squamous. So probably you can get a review of the histology done to make sure we're not missing out on an adenosquamous. It could probably be like an adenosquamous histology here, which is why probably it's throwing up this unique mutational profile. And if that's the case, also you can do a HER2 by IHC also. Check on the HER2 by IHC. And you could probably look at using TDXT as an option because of the presence of this particular HER2 activating mutation, irrespective of the HER2 IHC on expression. So that's my thought process here. Given that the patient has already progressed on 2 lines of therapy, and this is your 3rd line of therapy.
Okay, thank you.
Okay. Naren, can you summarize?
So here we are, ALK IHC we are suggesting because we don't know some if fusion partner is not there, it can be uninterpretable. So that's why we are suggesting ALK IHC here. Can someone correct me?
Yeah, and then TDXT.
Yes, sir. Yes.
Yeah. So okay, the final consensus is to do ALK by IHC and HER2 by IHC. And as of now, based on this NGS report, it's not targetable. If ALK is positive by IHC, maybe some fusion is there, which you are missing by NGS that can be targeted. And HER2 also, if positive by IHC, another option will be TDXT.
Yeah, irrespective of the status by IHC, I think. Because the HER2 mutation.
TDXT can be used for HER2 mutation. Okay. Okay.
TDXT can be used. Okay.
Yeah, it's a non-activating HER2 kinase domain mutation.
Okay.
Next, I'd call Dr. Thank you, ma'am. So I'd call Dr. Mangai from Kaveri Hospital, Trichy.
Good evening, sir. I'm presenting my case. Good evening, everyone. Next slide.
Yeah, good evening, Mangai.
Sir, patient is a 31-year-old male. He came with exertional breathlessness and cough and found to have a massive pericardial effusion. And subsequently, on evaluation, he was diagnosed with lung malignancy, sir. So his family history, his mother recently, 6 months before his diagnosis, his mother was diagnosed with breast cancer. She just now completed her treatment. And they also told a maternal uncle also had, mother's brother also had cancer, but they are not sure about the details, sir. He's a non-smoker. So coming to the case details, he presented with a cardiac tamponade and with an exudative pericardial effusion. Upfront PET scan showed 2 lesions in the brain, frontal and temporoparietal, and also he had a supraclavicular neck node and a lung mass which is in the left perihilar region, encasing the bronchus with the mediastinal nodes, bone lytic lesions, and multiple intramuscular deposits. He had a lot of nodules in the skin. So the biopsy from the neck node was a poorly differentiated carcinoma, TTF1 positive. Next slide, please. So, the patient, he was treated with 3 cycles of pemetrexed carboplatin, and after that now he is symptomatically better, and PET scan we did after 3 cycles was showing a partial response. So for him we did a tumor NGS panel. In tumor NGS panel we had a BRCA2 mutation detected. So since mother also had a breast cancer, we did a hereditary germline panel also in the blood that also showed the same mutation. So my question to the board, can you go to the questions, please? Sir, in how common is the BRCA2 mutated lung cancer, sir? What is the incidence and how they perform overall? Because he's a very young patient, recently married also. And the next question is, his BRCA came positive, but HRD didn't pick up. HRD is negative. So will olaparib be effective for this patient? And also, patient I had counsel for the addition of immunotherapy. We also did a PDL1. PDL1 IHC was 40%. So I told addition of immunotherapy also. So far they are not affordable. So what is the role of bevacizumab for this patient, sir?
Can you show the report?
Arun sir, Simbu sir.
Yes, sir. So this is a BRCA mutation, well characterized. It's a loss of function variant. Now, this patient is a lung cancer with the BRCA mutation. So there is no, I don't think we have evidences for any. I'm not sure. I don't think we have evidences for any BRCA-directed therapy like PARP inhibitor in a lung cancer case. But otherwise, this is a pathogenic mutation. But what is interesting to see is, although this is a pathogenic mutation, the HRD status is negative. So that is something we need to vary about. We need to be clear about, which means that this mutation may or may not be translating into clinical this one. I'm sorry, not the lung. This is a breast cancer, but it's not getting translated into HRD positivity. So there seems to be a discordance there in this breast cancer case.
So then
I'm not sure how, generally, because this is definitely a VAF is 48%, so 99% sure it's a germline variant. HRD is negative, but
Dr. This is lung cancer only.
Yeah, it was
this is lung or
lung.
It was
Lung,
but
lung only. Mother
no, but the
breast cancer.
specimen
Mother
is
families.
breast. Okay, so
Is
the
it?
specimen was breast, so I was a bit confused.
No, that's the mother. That's the mother is also being
Mother's
yeah,
tissue.
Yeah.
Okay.
Ah, that's what. It's a mother's tissue.
So that's where I got a bit confused. Okay, so this is a mother's tissue, but the patient is of lung cancer.
Yeah.
And both of them have the same BRCA mutation. That's BRCA2.
Yes.
If somebody go to little bit up, I think it is lung only. Can you go little bit up the first page? Yeah. Here it is. So this is the patient of male patient only, right?
Yes, sir. Yes, sir.
This is the male patient. This is a male patient, and this is a lung cancer patient.
Yes.
Correct. 31 years.
Yes. So as Dr. Arun mentioned, BRCA2, even though in the lung cancer there is no much evidence for using olaparib, and a very interesting point as Dr. Arun mentioned, even though the VAF percentage is 48, it's surprised to see the HRD is negative. So that's very clearly telling that functionally it may not be much effective. We don't know. The answer is we don't know. Only thing is clear from here is germline testing. When you have done the germline testing, there also we are seeing positivity, pathogenic mutation. So that means there is a family history is there. So we may suggest this family to test it out for the BRCA2 testing. The same variant is present in other members. For that, I think Dr. Brinda will be the right person to comment on it, how to go about it for the family member testing. But treatment-wise, with this BRCA mutation, I didn't feel confident for using olaparib, basically.
Yeah,
Or
very
any PARP
interesting
inhibitor.
point. Very interesting point. You can see there were two mid-genome reports here, right?
Yes,
One
sir.
is from the breast tissue, the other is this one that you are showing.
From the lymph node.
No,
Yeah.
sir.
So,
No, sir. One is neck node tissue biopsy. Another is a germline from the blood, sir.
okay. So,
PDL1.
okay. So in that case, fine. So which means that whatever we discussed till now, because I'm getting a bit confused with some other report, I think maybe. Okay. So in that case, this is not correlating. I don't think you would be able to, patient would benefit from PARP inhibitor much, even though the patient has this germline BRCA variant.
Sir, we don't have any other genetic variation in the blood, in the tumor tissue, sir. So if BRCA is the driver and it caused this tumor without any genomic scar, then how it is causing disease, sir? There is no alteration in the HRD. So we should repeat a HRD in tissue. Is it
No,
there?
I
BRCA
would
can
like to
cause
comment
not.
here, sir.
Yeah, please, ma'am.
So now HRD, coming to the HRD score here, genomic scarring score is independent of the HRR gene mutation, right?
No.
Because HRD score is basically the genomic scarring which is caused due to your loss of heterozygosity or telomeric allelic imbalance or your LSCs basically. And generally, when it comes to the scoring score score is based on the summation of these rather than the HRR. But this is my this one whatever the study I have seen or I have gone through. I want others to have their comments also.
So essentially, when there is a BRCA mutation, the pathogenesis or the mechanism of pathogenesis of BRCA is to create a HRD phenotype and cause metastasis or cause oncogenesis. So that's the reason why in most of the cases, whenever you see a pathogenic BRCA mutation, you tend to see HRD to be high. But in this case, it is not getting translated, which is kind of a paradox.
Probably could it be a technical issue as well, because the low tumor purity is only around 10%.
Tumor content 10% is good enough actually. I'm not sure. Maybe see again, this is a laboratory developed test.
Correct, LDT. It's an LDT, so probably the threshold for underestimating the HRD genomic score. That's one thing that I could think of. Other thing is probably other thing is biological reversion mutation or a secondary BRCA2 reversion, but that's also not been picked up.
It's not picked up.
It's not been picked up. A BRCA2 reversion mutation also has not been. And the other thing is probably a functional assay, like we discussed earlier. This is not a functional HRD that's been done here, so we don't know if the functional HRD is could still be positive. We don't know. But nevertheless, I think, coming back to your question, Mangai, for BRCA1 and 2 germline mutations, it's been reported in roughly around 1 to 3%. I mean, like, very rare, especially in lung adenocarcinomas. They happen to be seen in non-smokers and pretty young patients as well. Usually TTF1 positive, and they tend to co-occur with either P53 or RAS wild type. They tend to be RAS wild type, and they could have co-mutations in P53 as well. But nevertheless, they tend to be pretty responsive. You've probably given platinum here, and the response. How was the response to platinum?
Yes, responded, sir. There is a partial response now after 3 cycles.
Yeah, and also I think that's perfect. Then you could go ahead and continue with that. See, even though the PDL1 here is high, the MSI is not, and the TMB is also low. So probably, and your patient has got financial constraints for using IO as well.
Yes,
so
sir.
You can just go ahead and continue with your platinum-based doublet here, and then go on to maintenance with pemetrexed. And as far as your question with bevacizumab is concerned, very clearly now there's a ASCO recommendation saying that if you're using pemetrexed with platinum, do not use bevacizumab. even in adeno. If you're using taxane, upfront, or even nab-paclitaxel or any of that upfront, then you could probably look at using bevacizumab. But here, for somebody with a pathogenic BRCA2 germline mutation as well, who's responded well to platinum, go ahead, continue with the platinum, and then finish and put them on PEM maintenance. Not much of a benefit with adding bevacizumab here, especially with PEM. And also PARP inhibitors, absolutely not approved, and especially here, not approved in lung cancer, and especially with the HRD being negative as well, very questionable benefits. So
it is a very low incidence, no, sir. So will we get data for BRCA mutated lung or some HRD in lung and all? So for this patient, he's very young, sir. So
unfortunately, yes, these are all rare things, but like how we spoke about.
Off-label, can we recommend, sir? I'm not sure whether
Kripa and Silambarasan, I just have one thought. Whether this patient had germline mutation and whatever, and that germline mutation is picked up in the tumor tissue also. But whatever that has happened, it's a sporadic event. Probably you for any oncogenesis, you need both should be mutated or both should be lost, or one should be dysfunctional, right? So patient has a germline mutation, but what the lung cancer, what it is, probably it may be a sporadic, and whatever we are seeing in the tumor is more of a germline mutation, what we are seeing. But that is not the cause of oncogenesis.
Correct, sir. But I think the mother also had mutation, right, sir? Mother had the same BRCA2 mutation. Was that?
Yeah, so germline is there, but it doesn't mean that that is the one that is causing the malignancy. This can be a sporadic event, right?
Mother germline is not yet ready, sir. We have sent for
not yet done. All this hereditary panel also done is only for the patient, basically.
Yes,
so tissue for the patient, blood for the patient only we have done and proven that it could be a germline. Mother is, I think, yet to receive the result.
Yeah. So the patient should have one mutated, other should be a loss of function, or both should be mutated. Both biallelic loss should be there. Okay. So probably patient is having a germline mutation, but this event is probably a sporadic event. That's why it is not translated into HRD.
Could be, sir. And is it a biallelic loss here? I think it's a biallelic loss here.
No, sir. How biallelic loss would happen only when you have a HRD high, because the other allele would get deleted. But here the VAF is 48%.
As soon as you see the biallelic loss, sir, definitely any lab will give HRD positive. They will close the eyes and they will give HRD positive. Here, that to prove that there is no biallelic loss so far. As Dr. Arun mentioned, so far the HRD is not positive, so may not be biallelic loss so far.
I think, yeah, so between monoallelic versus biallelic loss, if it's a monoallelic loss, then obviously your PARP inhibitor is definitely not going to be effective, number one. Compared to a biallelic loss. And again, as far as the HRD testing is concerned, let me tell you again, there are caveats. We have the genomic instability score, most of them are LDTs as well. So for example, the cutoffs are different. The Myriad My Choice CDX uses a cutoff of 42, whereas your HRD track from MedGenome, they use a cutoff of 50. Whereas if you look at the genomic GAS or genomic aberration signature, which is what being reported here, they have used a different cutoff, more than 60. So, I don't know about how they've looked at the concordance between these different scores, because as was rightly pointed out earlier, it depends on the, the loss of heterozygosity, telomeric allelic imbalance, and also the large scale state transitions, all these three things together. But again, if you look at all the Indian-based HRD tests, they look at indirectly looking at these things by looking at the length, type, and site of centromere, the copy number, the length, type, and site of copy number. So, they are indirectly looking at the same things, but through a different way. So, which is why the standardization, and I think we've had this discussion with Dr. Arun as well, Arun sir as well earlier, where we knew that the loci of the allele are different. Even though they're looking at the same alleles, the loci of those alleles are definitely different, which is why the standardization and the cutoff values are different as well. So I think for me here what has been reported is the GA score. Is that right, Mangai? It's not the genomic scar score. It is the GA score or the genomic aberration signature. So I don't know about the concordance between genomic aberration signature versus genomic scar score versus the genomic instability score. So I think I would take this HRD report with a pinch of salt. And if you're really in doubt, get a Myriad My Choice CDX done, because that's the FDA approved companion diagnostic, and that will probably give you a better indicator as well. and if not, a functional HRD as well, as we were discussing earlier. I mean, that's just my 2 cents. Probably Arun Kumar sir and Simbu, you guys can also chip in.
Sir, just a
I
question.
completely agree.
Totally,
As
I'm
a
with you, sir.
content,
Maybe we may need to do the HRD testing separately. As Dr. Arun mentioned already, this is LTD only, lab developed test only. So no harm in doing one more HRD testing separately so that we will have a better clarity on the idea.
No, but I just
here
have
the tumor
a
content,
basic.
the tumor
Yeah, so,
content is 10%, and this young patient, what else is driving? Should we repeat the biopsy and then send? Because the tumor content 10% is not from the primary sites, it's from the lymph node site.
yeah. Ideally, you can try doing a liquid biopsy or get the primary site tissue and do the testing, sir.
Sir,
That could be
he
another
had a
option.
pericardial effusion. He was very sick, so they did a bronchoscopic biopsy. It was inconclusive, sir. Then only we did
Okay.
this is a second biopsy. First biopsy, it showed only malignancy. They were not able to do IHC also. That is why then this neck node was accessible. We took it from there.
Okay, maybe a liquid biopsy can also help. But I just also had a follow-up question for the previous discussion. Even if it is HRD positive or even if it is BRCA driven tumor, in a lung cancer, would you be comfortable using a PARP inhibitor?
Definitely not. We're not going to use PARP inhibitors. Definitely not now. Probably,
Yeah.
we already discussed about once they've exhausted all standard of care options, left with no other options, then we could look at using it. But definitely otherwise not. No, I mean no role for PARP inhibitors right now, sir. Absolutely.
Yeah, because even in ovarian cancers, where its main indication is for PARP inhibitors, after the second line, the sensitivity of PARP inhibitors reduces drastically. So, which is where I'm not very comfortable even using PARP inhibitor in lung in a later line after 3-4 lines of therapy.
I think probably, once we've exhausted all the standard of care options there, because there's no standard then. I mean, it's basically your discretion. It becomes like tumor agnostic therapy. And again, there is data called the Lodestar data as well, as far as tumor agnostic based on just HRD. Unfortunately, the response rates in HRD negative patients were 0%. HRD positive, rucaparib showed 30% response rates across all tumors. It's again phase 2 data. So probably they did include patients with other tumor subsites as well. So I think later lines of therapy, yes, up for debate, but probably worthwhile contemplating if you have no other options. But otherwise, right now, absolutely no role for any PARP inhibitors. I think the discussion was academic for us to about standardizing the HRD testing, because each lab gives you a different score, and also the validation across the board. So I think that's where I was trying to make that point about having to do if at all you're getting a HRD testing done, then I think it needs to be probably corroborated, because otherwise we might end up with the same situation where, okay, fine, even if it's a biallelic loss and you don't have HRD, I think there's no other reason for us to explain that.
And also here, sir, and also here, now if you see, as the doctor said previously, whether BRCA2 is really a driver mutation here is one more doubt, being a germline. But however, my other question is, mother is being a breast cancer patient, she's her report is pending then. Suppose if she turns out to be BRCA positive, that there may be some other syndrome also existing in the family, irrespective of whatever the lung cancer this person has. So should we recommend for a further germline testing for the family member, for the family member?
Yeah, that I would invite Dr. The genetic counsel now. Somebody was there.
It is a little of a paradox
Brinda,
because,
yes,
doctor, because I think considering the pathogenicity, it is warranted as per guidelines. But whether it is really driving the incidence of cancer in the family is query here. So I'm at a loggerheads actually. I'm also not able to tell very clearly. But if you have to go by guidelines, I think it is recommended to screen first degree relatives if we go by guidelines. Yes.
Agreed. I think for a germline pathogenic variant, especially, the incidence is very low. It's only around 1 to 3% as for lung adenocarcinomas, but it tends to be more BRCA2. as even if, it's not BRCA1, it's more like BRCA2. Here also it's a BRCA2. So, might be, we're not sure as to whether we can't pin it down, but probably I think, we've sent for a germline as well, right? So I think once we have those reports, be better for us to corroborate everything and put it together.
So final conclusion, this is not looking like a driver mutation. So continue with the chemotherapy if can afford add on immunotherapy. Otherwise, continue the same line of management. Since the young patient, no driver mutation identified from this tissue biopsy block, can consider liquid biopsy to identify any unknown driver mutation is there or any fusion is there. And regarding this HRD, to know whether it is positive, we can consider HRD median diagnostic testing to prove it whether it's positive or negative. And also consider the germline testing in the family since it's pathogenic.
Yeah, thank you, Dr. Narendran. So finally, we have come to the end of today's session. So once again, I would like to thank all the participants and the experts for the wonderful academic discussion. Also, I heartily thank the chairperson for today, Dr. Tejeshwar, who accepted our invitation to participate as well as to contribute in today's session, despite being a weekend evening. I also thank the technical team members. So wish you all a wonderful weekend ahead. Thanks.
Thank you, sir.
Thank you.
Bye.
Thank you.
Thank you all. Bye.